fact, a lot of the things that she was talking about and showing there are relevant for the next presentation, which is about a Norwegian Locked-In Syndrome Centre. We're going to hear from Helle and Jane, who work there doing the marvellous work at the Norwegian Locked-In Syndrome Centre, NoRLIS. Jane Svartskuren is the coordinator of that NoRLIS since 2017. She is an augmentative and alternative communication special education teacher. She's got experience from various areas, including AAC product management and development in Scandinavia, the UK, Holland, and other places, and a technical aid centre, adult education and schools. She's accompanied today by Helle Walseth Nilsen, who is a physician, a specialist in rehabilitation medicine, working at the Sunnaas Rehabilitation Hospital in Norway, which is where NoRLIS is based. She's been there since 2015. She's currently writing her doctoral thesis, How I Live My Locked-In Life, based on the Norwegian Locked-In Syndrome patient population, partly using registration data from the NoRLIS data. Their presentation is about the rehabilitation of locked-in syndrome people, the introduction to the Norwegian system for treatment and follow-up of locked-in syndrome patients. In Norway, it's mandatory for all hospitals to refer patients diagnosed with locked-in syndrome to the unit, the NoRLIS unit at Sunnaas, the rehabilitation hospital. NoRLIS provides interdisciplinary assessment at the acute ward, subacute inpatient rehabilitation, lifelong annual follow-up visits at patients' homes, as well as outpatient evaluation or shorter inpatient stays if required. It's an absolutely wonderful centre. I went over at the invitation of Frank Becker, who we're going to hear from after Helle, after lunch actually, after Helle and Jane's, and it's a marvellous facility. Implementation of augmentative and alternative communication devices varies according to the unique needs, capabilities and environment affecting each individual, necessitating adjustments and reassessments over time. NoRLIS provides counselling and guidance for the patient, their family members and relevant professional groups as needed. NoRLIS has tasks related to knowledge, dissemination, quality assurance and research. All people with locked-in syndrome in Norway are entitled to cost-free treatment, that will interest you, Fernando, and rehabilitation both in hospitals and within municipalities. All the technical aids, including AAC-devices, are fully funded by the government. So I'll hand you over now to Helle and Jane. Thank you.
Thank you, Shannon. My name is Jane.
Yes, my name is Helle, and as you said, I'm a physician now, nearly 10 years now at Sunnaas Hospital. Let's share our presentation. Yeah, and also, yes, I am currently doing my PhD on locked-in syndrome. And as you can see here are some pictures from Sunnaas Hospital, which is located right outside of Oslo, the capital of Norway. And the hospital provides a variety of rehabilitation programs for many different diagnoses, including stroke, traumatic brain injury, and spinal cord injury. And today we are presenting the Norwegian National Unit for Rehabilitation of Locked-In Syndrome. So let me first give you a brief introduction to the Norwegian healthcare system. It is divided into 3 levels: state, county, and municipality. And although the county has some responsibility, note that the healthcare system is primarily divided into 2. So we have the specialized services, for example, the hospital services, and the primary services, which are the local services. And as we already mentioned, all citizens have the right to free medical care, both in hospitals and primary healthcare. And this is regardless of who that patient is. And also costs of mobility and communication aids are covered. And the healthcare system is funded through taxes, mainly directed to the state, and some user fees. The system is based on equal rights to ensure equal treatment for all patients. However, there are some limitations to the systems, and we do find that there's quite a variation between the patients in what follow-up they actually do receive. For example, all patients are by law entitled to receive medical follow-up and care in their own homes. However, some low-income municipalities, they have limited resources and may prioritize institutional care due to the costs. And as they are responsible to offer all their citizens sufficient healthcare, they can argue this principle and then decide what care to provide. So they are not obliged to follow the recommendations made by the specialists. And we in the Norwegian National Unit for Rehabilitation of Locked-In Syndrome, we are part of the specialized services. And also note that there are some limitations in other areas. There are limitations in coverage of cost of exercise aids. There's also an age limit to that. And there are some strict criteria for some of for coverage of some of the aids. And we also do see discontinuation of individual aids and therapy upon institutional admission, as aids and services are expected to be provided by the institution. So today we are presenting the NoRLIS unit and how we organize this follow-up of all the locked-in patients. With permission from Terje, we are allowed to share his story as an example. Terje was 29 years old, working full-time and living at home with his partner and their young daughter. In 2011, he had a lot on his plate during a stressful time in his life. He was helping his mother move some furniture, and this is a picture of him and his mother, Veronica. While he was driving, he experienced a sudden chest pain and was admitted to the hospital. His condition deteriorated, and the CT scan revealed that he had a massive brain hemorrhage, and it was causing pressure and injury to his brainstem, as well as threatening his life. So he was in need of urgent life-saving surgery and spent months in the hospital. At some point, he was diagnosed with locked-in syndrome and was in need of rehabilitation. He was admitted to Sunnaas Hospital and then to another rehabilitation facility. Upon admission, he was placed in a nursing home, despite his wish to live at home with assistance. We will come back to Terje's story at the end of our talk. First, I want to present to you how NoRLIS have decided to define locked-in syndrome, just to let you know which patients we do treat and which ones we don't. So, as mentioned, all hospitals in Norway are obliged to refer all patients with locked-in syndrome to Sunnaas Hospital, and these patients have locked-in syndrome due to an acquired injury to the brainstem. So these patients typically have had a stroke or a traumatic brain injury, or they could have had an infection or other lesions in the brainstem. However, we do not serve patients who have locked-in syndrome caused by ALS or other progressive illnesses, such as a malignant tumor, for example. So, in addition to having a brainstem lesions, we have these criteria that the patient needs to have severe communication impairment, paralysis, in all 4 extremities, making them completely dependent on help in all activities of daily living, and having a normal or close to normal cognition. And by this we mean they need to be oriented for time, place, and situation at a minimum. So, as you know, patients often present with a classic locked-in syndrome, completely depending on their eye movements to communicate. However, most patients we see regain some function beyond eye movements, and they are defined as having an incomplete locked-in syndrome. We often find that patients regain even more additional function, even several years after the LiS onset, and we discovered the need to have a definition from when their progress in different function no longer aligns with the term locked-in syndrome. So let me explain. So you can see in this red box, it says not locked in by definition. So let's say some patients regain the ability to make sounds or occasional words. However, if a patient regains speech, allowing them to mainly communicate verbally, they will no longer be defined as having locked-in syndrome. And also some patients regain function in their arms or legs to allow them to use a switch or joystick, or they regain some ability in their legs to be able to come into a standing position with assistance. However, if a patient regains the ability to individually do tasks of daily living by themselves, like eating, they will no longer be defined as having a locked-in syndrome. Also, if you can walk a few steps independently with the mobility aid, for example, they will no longer be defined as having a locked-in syndrome. Concerning the cognitive function, in some cases, we do see that a patient might suffer a new stroke, leaving them no longer meeting the cognitive criteria. So Jana will now present our LiS service and how we work. I will just say that all the patients that are referred to us do get an evaluation and follow-up, but those patients that stay in a locked-in state for more than 6 weeks, those are the patients that we do the lifelong follow-up. And this lifelong follow-up is regardless of if they stay in a locked-in state or if they emerge from the locked-in state later on. And today this includes 35 patients, and half of them are no longer in a locked-in state. And every year we include 0 or up to 3 new patients.
Okay, thank you, Helle. As you said, all stroke units in Norway are obliged to refer their patients to the National Unit at Sunnaas Rehabilitation Hospital. Our assignment is to provide health care for all patients in need of specialized service. We observe and disseminate treatment results. We participate in research and establish a research network. We contribute to relevant education of healthcare professionals. We provide counseling and advice for users and for health and other relevant services. We also ensure equal access to the service and contribute to implementation of national guidelines and evidence-based practice. At Sunnaas Hospital, we work interdisciplinary. We have an interdisciplinary team with MD, nursing staff, OT, PT, SLT, pedagogue, and so on. And as Helle said, Sunnaas Hospital is a regional rehabilitation center. I said that. And there's an excellence team, or the LiS team. We also work interdisciplinary, led by the head physician, which is sitting here next to me, with the research competence. We also have an external reference group, which consists of representatives from each of the 4 Norwegian health regions, also family doctor and user representative. In the acute phase, Sunnaas Rehabilitation Hospital provides the following clinical services. So during the acute phase, we provide counseling of the ICU or stroke unit personnel by visit and or video conference. We provide information to personnel, patient, and relatives. And during the subacute phase, we provide a direct transfer to inpatient rehabilitation as soon as the patient is medically stable. And during the phase of transfer to community, our team members visit local team, we facilitate transfer meetings for telemedicine, and we arrange follow-up meetings with the local team after discharge. And further follow-up, we offer annual follow-ups via phone, video conference, or in-person visits. And if necessary, patients are offered readmission to Sunnaas. The Center of Excellence Services, which is the LiS team, provides educational and counseling services for patients, relatives, and healthcare and other personnel. For example, seminars, brochures, website, lectures, and media contributions. We annually document patient follow-ups in a quality registry, and we do research. And annually, we arrange the brain camp LiS. So these are some pictures from the camp last year and a few years ago. And the Locked-In Syndrome service has organized the brain camp actually 9 times. And this camp, at this camp, patients, relatives, and assistants come together for a 3-day event held at a regular hotel. Participants challenge themselves by traveling, staying in hotels, dining with others, engaging in pool training, testing various aids, attending concerts, among other activities. And the purpose of the brain camp is to learn how to live with locked-in syndrome. And they often say that a saved life should be a lived. In 2023, we held a camp at Sunnaas Hospital, and all the camps have been funded by the Sunnaas Foundation, which make them free for all the participants. When a patient is referred to Sunnaas Hospital, various professional groups collaborate to provide comprehensive care. However, from an AAC perspective, communication plays a crucial role in determining a patient's autonomy and overall well-being. Effective communication strategies, including augmentative and alternative methods, can significantly enhance a patient's quality of life. As I mentioned previously, to safeguard the patient's autonomy, it is crucial that the patient can communicate. And communication provides the patient with the opportunity to make choices and influence their own treatment. Patients can influence decisions related to finances, potential children, housing, etc. And additionally, patients can communicate pain or other needs during treatment and engage in conversations with both healthcare professionals and their family and friends. And finally, health information understanding. This term emphasizes the importance of ensuring that patients comprehend the health-related information effectively. This is what we call the AAC pyramid. At the bottom of the pyramid, we find early identification. And within the AAC field, there is unfortunately a culture of wait and see, also for locked-in patients. Here it is easy to base oneself on cases where it has not worked in the past. Therefore, it is important to tackle the first for people who lose the ability to speak after illness or injury. It will be absolutely essential to ensure that they get access to a way of communicating as soon as possible. It's important that you don't wait and see. And it is true that people with locked-in syndrome may feel unmotivated for AAC right after injury, but then you can give it a few days before you try again. Here one should be creative in terms of the approach. In more detail, this is how we operate with regard to the AAC intervention. In the intensive care unit, an assessment of the patient's communication abilities is conducted. Typically, a simple yes-no communication is established by having the patient look up for yes and down for no. Depending on the patient's level of alertness, various solutions for eye control speech devices are explored. Tobii Dynavox, often using a 16-inch screen, is commonly utilized for this purpose due to the need for a large display. We also use grid machines with large display. All communication aids are provided free of charge in Norway, and patients with locked-in syndrome should receive their assistive device within a few days. And these terms categorize different aspects of healthcare, included interdisciplinary mapping and the professionals typically involved in each category in the subacute phase. Health conditions and somatics, senses, motor skills, including positions, language and communication skills, I come back to that, understanding and cognition, and environmental control, environmental factors, and competence in the surroundings. The AAC mapping and interventions always builds on the basic mapping and takes place in parallel. We evaluate the patient's choice of expression, like graphic signs, hand signs, tactile signs, the choice of current symbol system, symbol picture, concrete photo, and so on, and assessment of complexity in the solution, the operation, very often is eye gaze, we use eye gaze, and choice of current aid or methodology. And finally, the use of augmentative and alternative communication, meaning what competence is available locally. And then finally, at Sunnaas Hospital, a choice of communication solution is made, and adaptation and training commence. When this charge is approaching, an AAC, a special educator, initiates training with the municipality before discharge and continues to support the patient within the community, both through video and in person. Local assistance and adult education centers also receive training if needed, and the patients are followed up by the LiS team throughout their lives. Helle.
Yes, thank you, Jana. So back to Terje's story. So Terje is today 41 years old. For the past 4 years, he has been living in his own apartment after having spent 8 years in a nursing home. So he has now 2 assistants available at all hours, working in shifts, and he himself had chosen all of the assistants for the job. He shared his story in this article in a Norwegian magazine, where he thanks his mother for fighting his case all these years, and they still have a close relationship. He says that his now 15-year-old daughter is more comfortable visiting her dad now that he lives in an apartment on his own. And over the years, he has regained some functions. He has the same personality as before, including his passion for exercise and tattoos. And as you can see in this picture, he covered up his scar from surgery with a tattoo of a zipper, which I think looks great. And now just to try to summarize, I would say that, of course, locked-in syndrome is a very rare diagnosis, and most doctors and healthcare workers have never met a person with LiS. So having a centralized rehabilitation unit allows for specialized services from a multidisciplinary team that has knowledge and experience with locked-in syndrome. And having outpatient visits ensures the patient's opportunity to report, for example, shortcomings in their local follow-up. You know, not all patients with locked-in syndrome have access or independent access to reach us by phone, SMS, or email. Therefore, we do these ambulance visits to their home to speak with them directly. And these annual visits include going through a checklist of questions covering all health aspects, including multidisciplinary follow-up, their training, aids, and mental health questions. This to make sure that we are covering all aspects in which we might be able to provide help. Also, we do provide this lifelong follow-up, and this allows us to for repeated knowledge transfer when there might be a change in the health personnel. So if a patient moves to another facility or gets a new physiotherapist or health personnel, we are able to offer them lectures on locked-in syndrome and guidance in communication, training, and daily activity. And this is important, this to educate those working with the patient. Healthcare providers and decision makers often have limited knowledge of locked-in syndrome or even wrong preconceptions of locked-in syndrome. So in many cases, our services help the patient by helping them communicate their needs and rights. Sometimes if there's a conflict between the patient's wishes and the local follow-ups that is provided to them. This LiS seminars and LiS camps, as already said by Janne, they bring the LiS patients together, meeting others with locked-in syndrome, other family members of patients with LiS, and other healthcare workers within the same field. And lastly, data from every annual visits are included in our quality register. And this register has provided us with information on this unselected population of patients with locked-in syndrome in Norway. And my PhD research project is partly based on this data that goes back to 2012. So my main supervisor, Professor Frank Becker, he will present our research in a later presentation today. So yeah, me and Janne, we thank you for listening to our presentation. Thank you.
Thank you very much, Helle and Jane. That was marvelous, really interesting. What a fantastic facility you have there. Having been there myself and walked around it and seen all of the things that you do there, it's so admirable. I wish every country in the world had such a thing. Unfortunately, even somewhere like Australia doesn't. It's a much huger country, but we don't have a centre specifically devoted to locked-in syndrome. And one of my aims with running the Australian Register for Disorders of Consciousness is ultimately to get a centre set up in Australia. So you've been a role model to us. Thank you. Does anyone have any questions? I think you covered everything very carefully. It was a really, really good presentation. Thank you. Any questions, anybody? Any more thoughts? We're just about to go into the break now. So if you do have any questions or thoughts, you can perhaps discuss them with us when we come back from the break. I'm not sure whether Helle and Jane will be with us, but their colleague Frank, who's also at the Sunnaas clinic, is going to be, as Helle was just telling us, is going to be doing his presentation immediately after lunch. So it's a sort of continuation of what the girls have been telling us today. Thank you very, very much. I think the next thing that we're going to be doing is we can, if anybody would like to have a sort of general discussion, can you put your hand up now on your Zoom system, and we can talk about anything that you've heard that's been in the presentations this morning. Anybody got any questions about any of those? It's been quite a long and involved morning. Someone's speaking.
Tina, you can go first. I think Tina was first. So
Sure.
Yeah.
Okay, thank you. I just wanted to ask a general question around communication devices. If there is a gap that is identified where there is folks that are locked in, but you can't reach them. There's still that gap. There's still something missing in your communication device area that you need to develop still. Is there something that you could identify that way? You're on mute.
We actually don't work with patients with total locked-in syndrome. I know there are some facilities using the EEG signals, but often we have some responses like the eye movements, and then Janne,
Yes.
you can use the systems for that.
Yes, we use, if you can't use like an eye gaze system, we have tried the brain-computer interface, but it hasn't been successful. But then we used sort of the yes/no as a partner assistant system. Then you ask questions and you have like a set of questions that you have in a book. And then you ask the same questions again and again. So it's predictable for the patient. So in a few cases only use the yes/no, but most patients can use either the Tobii system or the grid system with eye gaze. A few use a head mouse, and yeah.
So as you say, if you have one movement that you can say yes or confirm, then you can use like a spreadsheet so the patient knows, okay, we start off with this question and this question leads down this road or this road, so that they are able to communicate at least their needs and their wishes.
We call it PASS, a partner-assisted scanning. I think is a well-known system in the AAC world.
Okay, thank you.
Thank you, Tina. I think, Phil, were you wanting to speak?
Yeah, can you hear me okay?
Yes, we can.
Yeah, I enjoyed all the talks, thank you. Even though I wasn't visible all the time, I was still listening.
You were here.
A couple of comments on Professor Vidal's presentation. He was surprised about ALS versus brainstem stroke. There are very few ALS patients in Europe because, according to a Dutch study quite a few years ago, 93% of patients with ALS, when they reach the point of having to make a decision about a ventilator, they allow themselves to die. So they don't want to survive. So all you've left with are brainstem strokes due to producing locked-in syndrome. So I think when rehabilitation, good as it is right now, improves and people are able to speak again, I think it'll make a huge difference to whether or not they decide to survive. Because as we saw from Dick's presentation, I mean, there's a lot that these people, and also the other person, I can't remember her name, there's a tremendous life there. You know, I mean, we're alive, even though we're locked in, and we just have to release that. And I think speech is really important. And I think we're going to hear about that this afternoon, right, from Moses.
We are. We've got David Moses talking, and we've got Anne Johnson, who was a locked-in syndrome person who actually had the brain-computer interface implanted. So that would be really interesting. Those two are concurrent later this afternoon.
The other point of reference is that locked-in syndrome in general, due to a brainstem stroke, 1/3 will die, 1/3 will get better, and the other third remain locked in or coming out of it. So the variations in, so you hear about people getting better, well, they're not fully locked in, or they have some residual activity that they can, neural activity that they can, by practice and effort, they can actually get something like we were just shown. And I think that's very interesting. So there's a lot of hope for people with locked in. I think the whole field is changing, and technology is of course the answer. And of course, having good people in Norwegian and other places to actually apply that is key, and actually use it. And you mentioned, Jane, you mentioned that BCI didn't work. I think it was EEG they were using, if I understood. And that's the problem with EEG. It's not got high resolution. You need to go right into the brain. But that's another old story, so I'll keep quiet.
Perhaps you will tell us about that. Phil kindly has given us presentations in previous years, and he will be back, providing he continues to want to. He'll be back again next year doing a presentation on his current research, so we should be able to hear a bit more about what he's been
I
doing.
will continue to work, don't worry.
And Phil actually did a brain implantation on himself several years ago, which no doubt he'll tell you about in next year's. Give us all something to look forward to again, Phil. The other thing that, of course, is vitally important is the detection, being able to understand who is locked in. There's a lot of people in a lot of countries that don't have MRI scanners and don't have ways of actually even evaluating that the person does have full cognitive ability and is just locked in, and they're being classified as vegetative or minimally conscious and not being treated appropriately at all. So that's another huge area that needs to be addressed and is being addressed gradually, but we shouldn't ignore it.
Have you heard of, sorry, just to speak to that, have you heard of something what they referred to as vent farms in California, for example, by the thousands? Apparently they're kept on ventilators and deemed to be in a vegetative state, but perhaps as this rates, I've heard 40% are wrongly diagnosed, or maybe they have become awakened, but they're not being further tested. And is this something that you're aware of?
I had not heard of vent farms. I don't know if anybody else had that. It's a horrifying term, but at least the people are being kept.
Yeah, Fernando.
Yeah, I think I think the my impression is that the problem with misdiagnosis is that technology on the one hand, of course, is increasingly crucial to diagnose correctly, to discriminate between, you know, the vegetative state and wakefulness and responsive state and other states. But on the other hand, technology is making that process a lot more complicated because it has turned having consciousness and not having consciousness into a spectrum. So, you know, it's no longer that a person has consciousness or does not have consciousness or lacks consciousness, but there is a spectrum. So now, you know, now in the middle, there is the minimally conscious state. And in the minimally conscious state, there are degrees. So while technology facilitates correct diagnosis, it also generates more complicated situations. And I'm sure that Frank and Jane and colleagues have this experience. So yeah, technology is crucial, and at the same time, it raises new difficulties, new challenges. Again, because of the transformation of the state of having consciousness into a spectrum, basically, and no longer into something that is a yes or no matter. Sorry.
And of course, the spectrum is difficult to gauge if you're not getting a steady flow of communication.